Oops. We're going to keep going on our journey in the topic of anemia. We're going to start, we're going to continue talking about anemia as we started last time. So every time that we're talking about anemia, I want you to think about this. How were we able to classify anemia? What was the first question that you ask yourself whenever somebody presents you with anemia? What is the first question you ask?
Decreased production.
Is it increased production or increased destruction? Okay? Is it going to be reduction in production, or is it going to be because of the increase in destruction? And how would you be able to answer that question? Retic count. With reticulocytes count, you're going to be able to do that. Now, when your retic count is going to tell you that it's under production, what is the next step?
MCV.
You're going to look at the size of the red blood cells. And the value that you're going to go, indices that you're going to go and use is going to be MCV. Okay? And MCV is going to be more than 100. It's going to suggest macrocytic. Less than 80 is going to suggest microcytic. And between 80 and 100 is going to be normocytic. Everybody remembers that. Last time we discussed the time that it would be macrocytic, such as example that we had for the iron deficiency anemia, as well as the anemia of chronic inflammation or infection. So what's going to happen, this topic in here is going to be continuation of that. But this one is going to focus if your MCV is going to be greater than 100. You're having macrocytic this time, not microcytic. Okay? That's going to be a big difference. I want you to pay attention to that image on the board. Especially those that are going to have an arrow close to them. Can anybody elaborate on these two images? What do you think they are, first of all? They're immature red blood cells. Everybody sees that. You should be able to be at the stage to recognize that these are immature red blood cells and they're not white blood cells. But with little bit experience and curiosity, you're going to realize there is something funny about these cells. Does anybody have any idea what is so funny about these cells? What happens here is that this cytoplasm is orthochromic normoblast cytoplasm. You can see the pinkish color of hemoglobin quite apparent there. However, when I look at the nucleus, this nucleus is more of a normoblast nucleus. Or if I want to go and give credit, I say polychromatophilic normoblast. But I would say even before that, basophilic one. So what happens in this case of the macrocytic anemia is that there is going to be something we call asynchrony. Asynchrony is the time that you are not going to have the same rate of development and differentiation in the nucleus and in the cytoplasm. Cytoplasm is going to progress normally. Nucleus is going to fall behind. That way the nucleus is going to be younger, but the cytoplasm is going to be more mature. The reason is going to be in this kind of anemia, the problem is in DNA synthesis. When things are going to get to the cytoplasm, you're not going to have DNA in the cytoplasm, you're going to have mRNA. And that's not the problem. Everything's going to be fine with the mRNA. RNA is going to do right. The thing that's not going to do right is going to be the DNA. That's going to be in the nucleus. So the nucleus is not going to progress as fast as the cytoplasm. And that's going to go ahead and cause a problem. We're going to talk about that, how that is going to be possible. So we're going to talk about the etiology. So number one cause of macrocytic anemia is going to be vitamin B12 and folate deficiency. Okay? Number one cause. Does that mean that's going to be, these are going to be the only reasons? No, there are many other reasons that can give you macrocytic anemia. However, when we are talking about this case, vitamin B12 and folate deficiency, you will have a macrocytic anemia. There is a terminology we use, and I want you to become familiar with this terminology because we're going to come back over and over. We call that megaloblastic change. Megaloblastic changes. When we are talking about megaloblastic changes, we are talking about the fact that when you are looking at the bone marrow of this individual, you got to be able to see that there is active production of the cells. Cells are going to look much bigger than normal. You will even have hypercellular marrow. Think about what I'm talking about here. You will have hypercellular marrow, which means you are actively producing the cells. Sometimes you might even see the ratio, the normal ratio of myeloid to erythroid cells is what? 3:1. Sometimes you would be able, depending on the stage of the disease, you might see that this ratio becomes 1:1. How would you interpret this? There are two ways to interpret that. One is going to be that the production of myeloid cells has decreased. The other one is going to be the one that is the production of the erythroid cell has increased. That's going to be what's happening in here. The erythroid cells are going to become actively dividing, but the problem is that they are not going to make it to the end. Before they get to the point that they would be able to be released into the circulation, most of them are going to be destroyed. They are going to be lysed, hemolyzed, and destroyed. Okay, and that's where the anemia is going to start coming in. So megaloblastic change is associated with bone marrow changes. That's characterized by very large cells and hypercellularity. We will come back to this again, so make sure that you understand the concept of megaloblastic change. Now I want to explain to you what is the role of vitamin B12 and folate, because it's a really nice story and it makes complete sense. See folks, there are things, metabolism is the conversion of things in the body. Things are changing in order to produce energy, get rid of the waste products. You need to have metabolism. So what is going to happen here is that in your body, you got this amino acid. We call that amino acid homocysteine. Homocysteine, sometimes you are able to go and get the amino acids that you need through your diet. Sometimes you have to make them in your body. You're going to make one of these amino acids in the body. We call that methionine. So homocysteine is going to be converted into methionine. What's the difference between homocysteine and methionine? Methionine has a methyl group. It has a methyl. This is a methyl group. Okay? Now the question is that where this methyl group come from? All right. So this methyl group, so there is an enzyme in here that is going to need vitamin B12. Vitamin B12 that is going to be methylated is going to come here, and that is where this methyl group is going to be added from. This is the methyl group. And then vitamin B12 is a coenzyme. It's not going to be used up. It's going to be back where it is. All right? So in order to convert homocysteine into methionine, which is an amino acid, every protein in your body is going to start always with amino acid methionine. This is one of the trivial information. You never know when it's going to come and help you. Every protein, regardless what protein is, always is going to start with methionine. Remember that. This is knowledge. So if you are going to go ahead and make the methionine, you're going to get the methyl group from a vitamin B12, add it to the homocysteine, and you're going to have your methionine. But the question is going to be, where did this methyl group on the B12 come from? Where is this coming from? And the answer is that whenever you absorb folic acid is a vitamin, folate. Sometimes they call it B9. There are different names they use it. When you absorb the folate from your diet, you're going to methylate it and release it in the blood. So you are going to have methyl tetrahydrofolate. This is the way that the folic acid or folate is going to be traveling in your blood, methylated. And when we are talking about the vitamin B12 is going to have a methyl group to give to homocysteine in order to make the methionine. This methyl group, vitamin B12, got it from here. That's the way it is in the blood. That's the way it is. As soon as the intestinal cells absorb the folic acid, they're going to methylate it, they're going to put it in the blood. They don't even need a carrier. It's going to go directly in the blood. So what is going to happen here is that this methyl group is going to be very important, because after this vitamin, folic acid loses its methyl group, it's going to become just tetrahydrofolic acid. That's going to become. It lost its methyl group. Is everybody following me? Questions so far? Anybody? Okay. Now the key is that this TNF, tetrahydrofolic acid, is going to be used in converting. Does anybody know what uridine is? Does anybody know what uridine is? Have you heard of uridine? Have you heard of uracil? Uridine is going to give you the uracil. They are related. Okay? They're related. So when we were talking about DNA and RNA, there are several differences between DNA and RNA. One of those differences is that DNA has thymidine, T. RNA has uracil, U. That uridine is related to this uracil. Okay? This uridine is going to be converted to DNTPs. When I say DNTPs, I'm talking about adenine, thymine, and specifically if I are talking guanine, especially these two. We call these two purines. Just the name of this class. Now you understand when we are talking about macrocytic anemia is due to DNA metabolism problems. If you are not going to have A's and G's because you don't have the folic acid or vitamin B12, how would you be able to make the cell divide and give the daughter cells 2 equal amount of the DNA? You're not going to have enough substrate, enough basic material to duplicate the cells. So what's going to happen is that the cell division is going to be affected. The cell cannot divide. Everybody remembers this. I hope that everybody does recall this. Cell cycle. Biology 101. So a cell is going to have a cycle. You got the mitosis. Mitosis, after the mitosis is done, the cell is going to get into G1 phase. From G1 phase, you are going to be able to go and get into S phase. From S phase, you are going to go and get into G2 phase. And from G2 phase, you are going to go and get into mitosis. Mitosis, a parent cell is going to divide into 2 identical cells. These cells are going to be small. But as time goes by, they're going to grow. They're going to get bigger. Okay? There are 2 places. One of them is going to be at this point, between G1 and S. Another one is going to be at this point, before the mitosis. That's going to be referred to as, there are check systems there. You got a number of enzymes. We call these checkpoints. That if things are not done properly to this stage, the cell cycle will not proceed to the next stage. If things are not done completely to this stage, the cell is not going to proceed to the mitosis. The problem with the megaloblastic anemia, macrocytic anemia, due to this vitamin B12 deficiency, is going to come and bite this cell right at this point, the checkpoint. The checkpoint is not confirmed. The cell does not divide, go to mitosis. The cell is going to stay here and it's going to get bigger. And it's going to get bigger. So there is going to be a loss of rate of division when it comes to the cell cycle of the cells. Okay? So the cells are going to get bigger in size. And many of these cells are going to get so big they're going to get hemolyzed. Right in the marrow. I want to give you a new name. I want you to know these names. I have already told you about extravascular hemolysis. I have already told you about intravascular hemolysis. That doesn't mean I'm not going to tell you more about them, but you know what I'm talking about when I use those 2 terms, right? Yeah. Okay. I want to introduce you a new name. Intramedullary hemolysis. This is what happens in the case of the megaloblastic anemia. You have intramedullary hemolysis. Does anybody want to take a shot what that means? You get the red blood cells hemolyzed in the marrow. So if somebody wants to say, excuse me, I think that this is going to fit the category of extravascular hemolysis, I'm not going to disagree. It is a subtype of extravascular hemolysis. Remember, extravascular hemolysis is going to happen in the organs, such as spleen, such as liver. Bone marrow is an organ. Okay? It's a pretty big organ too. So it's going to happen in the bone marrow, so it's going to be a subclass of the extravascular hemolysis. But I want you to understand when we are talking about intramedullary hemolysis, we are specifically talking about bone marrow. Okay? Questions? All right. So what happens is that we presented two concepts here. One is B12 deficiency, the other one is folate deficiency. You can have B12 deficiency, no folate deficiency, or vice versa. You can have enough B12 but no folate. Either one can happen. The question is that how would you be able to separate these two different problems? How would you be able to pinpoint, hey, this guy needs B12 shots, and this guy needs to eat more vegetable because that's where you're going to have the maximum amount of folic acid, the green vegetables. How would you be able to determine that? And the answer is very simple. You got to know a little bit about B12. Because B12, folate, this is what it does. It's important in the production of DNA nucleotides, so you would be able to replicate properly. The nucleus of the cells would be divided. But when we are talking about B12, that's one important function, to be able to give the methyl group to the homocysteine. It does another thing. B12 does a very important thing as well. And that important thing is going to be being involved in oxidative phosphorylation. When you are talking about, the Krebs cycle, the electron transport chain, production of ATP, when you look at those Krebs cycles, you're going to be able to see there is a compound called methyl malonyate, CoA. This is a compound, part of the Krebs cycle in oxidative phosphorylation. Okay? This compound is going to be converted into another compound called succinyl CoA. Okay? This requires B12. There's another enzyme involved here, but the B12 is going to be a necessary cofactor in this process. Okay? So what's that going to do? Now I want to go ahead and ask you the same question. I want someone to give me an answer. How would you be able to differentiate between folic acid deficiency and B12 deficiency? How would you be able to do it? What would you test in the blood? Because if you have B12 deficiency, what do you expect to go high in the blood? If you don't have the B12 to give the methyl group to methionine, methionine is going to go down. What's going to happen to homocysteine? It's going to be elevated. Same thing is going to happen with folate. Because if folate is not present, where is the B12 going to get the methyl group? Nobody. Same thing is going to happen. You're going to have increased homocysteine. But if you are having folate deficiency, what is going to go up or down in here? Nothing. This is going to go just fine if you have folate deficiency. If you are having B12 deficiency, what's going to happen now? This guy is going to be elevated. We can test for this one. We can test for homocysteine. And this is the way that we would be able to go and identify whether or not the person is having the B12 deficiency versus folate deficiency. But I gotta give you a little bit more information in here, and I'm just going through the entire lecture so we can go through the slides quickly. Your body has your liver. That's where you store all the vitamins, your liver. Your liver has a store for vitamin B12 about 1 to 2 years. So if you stop consuming vitamin B12 today, it's going to take 1 or 2 years for you to see the symptoms. But when it comes to folic acid, take a guess how long reserve you got. 5 to 7 days. Okay? Now if you hear that, in my opinion, again, I'm not an expert in that field, but one of the most important supplements that women, and especially pregnant women, must take during pregnancy and before pregnancy. If somebody knows that they're going to become pregnant, it would be very smart to start taking B12 fine, but the folic acid. The folic acid is going to be very necessary, because without folic acid, the nervous system is not going to develop. So you're going to have the person that's going to be low folate, the fetus has low folate. When the fetus is going to be born, all of a sudden you can see the spinal cord is exposed to the outside, the cord is enclosed. Spinal bifida, that's what we call it, primarily due to folate deficiency. Okay? So it is very easy to deplete your resources for folate. It's not as easy to deplete your B12 because you have much comprehensive supply resource for the folate. So be aware of that. Even though B12 you have a lot of it, and folic acid you're not going to be able to keep it. It can vary depending. You sometimes identify, is it because of folic acid or is it because of B12? You cannot always guess that, oh, it's B12 or is it folic acid because B12 they have a lot of storage. Because there are other stories that happening with B12 that doesn't happen to the folic acid. Folic acid is going to get absorbed in the duodenum of the small intestine. The first part of the small intestine, duodenum, that's where you're going to absorb the folic acid. But there's a different story for the B12. When you eat your food, B12 is going to be present, it's not going to be much in the plants. There is no B12 in the plants. You're going to have in eukaryotes that are non-plant. What I mean by that is that you're going to have it in animals, but you may be able to see, so I don't eat meat personally, so what I eat, so my wife has got this red yeast. Yeast is a eukaryote. It's not a plant, okay? It's a fungi. And that red yeast is very high concentration of B12. Because if you're not eating meat, you're not going to have a source of B12. So you're going to become depleted over a year or two. The only problem with that is that it just tastes like shit. I mean, it is such a nasty thing. I just told him, mix it with something. I don't know what it is. Because you cannot pick up a spoon and put it in your mouth. It's just really nasty stuff. So that's the only problem. But otherwise, I can get it because if you're a vegetarian, you're going to know about that. That would prevent you from becoming B12 deficient because there is no other source for you to get your B12. Okay? Unless you take pills. Okay? But when we are talking about taking pills, there's going to be a problem. Sometimes we develop a condition. That condition is going to be referred to as pernicious anemia. Pernicious anemia. Now, what is pernicious anemia? It's due to B12 deficiency. Hold on. Don't jump to the conclusion. I didn't say you are not eating B12. I say B12 deficiency. There is a problem for the B12 to get where it's supposed to go. And that is going to be a simple story. In the case of the pernicious anemia, we develop an autoimmune disease. So this is the way that you're going to be absorbing the B12. Let me tell you that first story. When you're chewing that meat that you're eating and you're absorbing all the B12, in your saliva, in your mouth, when you're chewing the food, that B12 is going to get coupled with the protein. We call that R protein. R protein. The purpose of R protein is that you don't want the stomach acid to break down this B12. You want to protect it. And R protein is going to protect the B12 integrity in the stomach. Okay? But when the B12 and R protein combine, get into the stomach, nothing is going to happen. But what's going to happen is that your stomach is going to produce an enzyme called pepsin. Pepsin is going to start to cutting R protein from the B12, separating it. But this process is not instantaneous. It's going to start working. And by the time that is actually going to be working, that B12 is going to be in the duodenum. Where is our protein coming from? Saliva. Our protein is coming from saliva. It's going to protect the B12 from the acidity of the stomach in the stomach, but stomach is going to produce an enzyme. What is the name of that enzyme? Pepsin. Pepsin is going to start chewing off this protein, so it's going to release the B12. When it gets to the duodenum, here we got our B12 ready to go. However, there's a catch in here. In your stomach, you got a group of cells, the same cells that produce the acid in your stomach. We call those parietal cells. Parietal cells are also going to produce another compound that is called intrinsic factor. Intrinsic factor. When the duodenum, in the duodenum, B12 got separated from the R protein, B12 that is alone should not stay around because the bacteria in your gut will take it up and will use it up quickly. So what happens is that that intrinsic factor is going to come and bind to the vitamin B12. Vitamin B12 is going to be absorbed in your ileum. So if you remember from your anatomy, your small intestine is divided to three parts. The first part is duodenum. Some people call it duodenum, no difference. The second part is jejunum. And the last part is ileum. It is in the ileum that you absorb B12. Nowhere else. In the ileum only. But you know how you absorb B12 in the ileum? You're going to be endocytosing that B12 intrinsic factor combination. Now there is a very unique pattern in here. If this is going to be the intestinal cell. So this is going to be blood down here. This is your B12 and intrinsic factor. The key that is going to allow the endocytosis of this combination is going to be the intrinsic factor, because the gatekeeper on the surface of these epithelial cells is going to have the match for intrinsic factor. So it is the intrinsic factor that fits in this groove, and B12 is going to be coming with the intrinsic factor. And that's the way you're going to bring it in the cell. In the cell, you're going to separate these two, and you're going to let the B12 go where it's supposed to go, to the liver or bone marrow, wherever you're going to go and need it. So did everybody understand? Absorption of B12 is not going to happen by itself. It needs, it's like glucose. It's very similar like glucose. Glucose cannot go through the cell membrane by itself. You need insulin to facilitate this process. B12 cannot go through the cell by itself. You need intrinsic factor to facilitate the absorption of the B12. Is everybody following me here? Okay? All right. We have an autoimmune disease. We call it pernicious anemia. That's where we start talking about this. In the case of pernicious anemia, your white blood cells, after you have exposure to a virus or some kind of agent, your immune cells become active. They produce antibodies against your parietal cells. They're going to go in and destroy the capacity of these cells to produce intrinsic factor. So they don't produce intrinsic factor in their stomach. What do you think that's going to do? You cannot absorb it. It doesn't matter how much B12. It doesn't matter if you eat the entire cow. You're not going to be able to absorb any of that B12 in the meat. Okay? Because you have an autoimmune disease. Now, what's going to be the characteristic of this kind of, pernicious anemia is that the cells are going to be going through the same problem. You don't have B12. What's going to happen with B12 deficiency? I drew it up there for you. DNA metabolism is going to be compromised. The cells cannot divide. The cells are going to get bigger. Okay? Most of them are going to go through the intramedullary hemolysis, and those that are going to survive, they're going to come out, but they're going to be what? They're going to be bigger in size. Okay? All right. Let me see if I have forgotten anything else to tell you. It's just not the autoimmune disease. You guys realize that there are different procedures. For example, gastric bypass. Have you heard of gastric bypass? Some people that are grossly overweight, in order to go in and reduce their weight, they're going to go in and reduce the size of their stomach. Okay? I don't advise to you to do such thing unless you're grossly overweight, that being obese that much that's going to affect your life and it's going to affect your health. In that case, they remove part of the stomach. When they remove part of the stomach, that part that is going to be removed is going to be the area of the stomach. So if this is going to be stomach, this is going to be fundus of the stomach, this is going to be the body of the stomach, and this is what's called the pyloric stomach. These are going to be the cells that are going to be producing that intrinsic factor. And this is the area they will remove. So if these people have removed that part of their stomach, they will need B12 shots for the rest of their life. Once a month, they have to go in and get a B12 shot. Not B12 pills. Why not? Why not B12 pills? If you understand the mechanisms, you want to answer any question that I give you. The problem that I have noticed after your first exam is that many of you like to memorize pieces of facts, but you don't connect everything together, how things come together. Okay? Everybody knows these facts and that fact and this fact and that fact, but the thing that you are missing is the connection between these facts. If you be able to connect it, you're not going to have any problem with this class. You're not going to have any problem with any of my classes. And you're not going to have any problem with anybody's class about any, as long as you be able to make a connection. Okay? All right. So I think I told you everything I remember. So let's see whether or not the slide is going to tell you more. So etiology is the origin of the disease. Where is it coming from? I think I've covered that pretty well. Okay. Oh. So what's going to be happening in here is that we got good clues. This is one of those cases that CLS texts are going to play a very important role. When you're looking at simple blood smear, you would be able to give enough information to the physician to make a diagnosis with one single blood smear. So tell me what you are going to be seeing. Again, one more thing I want to tell you before I go further, and that is that, see, things don't happen instantaneously in your body. So when we are talking about you are having B12 deficiency, you're not going to go from normal to abnormal in one day. It's a progressive process. It's going to slowly develop. So don't expect that everything is going to look exactly the way that I'm describing to you right now. It depends on what part of, are you just started to having the problem? Have you had this problem for a long time? Are you under the treatment for the problem? These are going to go and all factor in what kind of morphology you're going to see on the blood. So I'm just generalizing that the person was discovered to have anemia, comes to you, and that's what stage we are right now. But again, I want you to know when you're looking at case studies, always think about the whole picture, not just pieces, okay? What do you expect to see in B12 folate deficiency in your blood stream? You are going to go down and see macrocytic cells, right? In the CBC, you're going to have anemia. Remember why we are here, because this is an anemia. You're going to have low red blood cells, you're going to have low hemoglobin, you're going to have low hematocrit. but you're also going to have high MCVs. You understand that part? If you see more than one or two segmented neutrophils that are hypersegmented, which means that you are having 6 or more nuclei like this one. If this one has 1, 2, 3, 4, 5, 6, 7, 8, 9. That is pretty indicative of B12 folate deficiency. Now then you have to go ahead and decide, is it B12 deficiency or is it folate deficiency? And I already told you how you would be able to determine that. You look at the homocysteine and you look at the MMA level, see which one is going to be elevated or not elevated, then you would be able to go ahead and determine whether or not this is folate or folic acid. Questions? Alright? Nobody? Either I was very clear, everybody understood what I'm saying, or I was very unclear and nobody understood what I'm saying. There's 2 possibilities in here. Alright. So that hypersegmented neutrophil, from now on your blood films, you must report it. Because if I know this slide has hypersegmented neutrophil and you don't report it, you're going to lose points. Pay attention to that division of neutrophils. Now, let's make our criteria more than 1. If you see 1, fine, be aware of it, but you don't have to report it. But when you see more than 1, definitely report it. Definitely report it. Pernicious anemia, I told you about this one. I think that I told you this story, what's going to happen. You're not going to be able to absorb the vitamin B12 despite the fact that you have sufficient amount in your diet. And that's because you need the intrinsic factor. If you don't have the intrinsic factor, then you would not be able to go ahead and absorb it in the ileum. Screening, usually, let's ask this question, see who knows what. I expect the people in my urine body fluid class that are in here to answer this question, if the rest of you cannot. If you're having B12 folate deficiency, what is going to happen to the level of bilirubin in your blood? What's going to be happening with the bilirubin? Yeah.
It should increase due to hemolysis.
That's right. It should increase due to hemolysis in the bone marrow. You're absolutely right. Okay? But there are 2 different types of bilirubin. One of them is non-water soluble. We call it either indirect or we call it unconjugated bilirubin. The other one is water soluble. That's going to be direct or conjugated bilirubin. Which one of these is going to increase? Are you going to be seeing
Unconjugated.
it's going to be unconjugated? What is that what I heard?
Yes.
Yeah.
Why unconjugated?
Liver will not be able to compensate for this.
Did I indicate anything about the liver is not working properly? If the liver is working properly, what do you think is going to happen? The liver is going to be able to conjugate, right? It's going to, so what are you going to be able to see in turn? If you are able to produce a lot of hemoglobin, bilirubin, and you're going to be able to conjugate all of it because you have a healthy liver, the story would be different if you don't have a healthy liver, which is the case many times. But we are talking about the basics. If you are going to have a healthy liver, and that liver is able to conjugate all that bilirubin, what is going to go and indicate that? Urobilinogen. Because when the bilirubin that is conjugated is put in the bile, it's going to go to the small intestines, and the bacteria in the small intestine, they're going to start to break down that bilirubin, right? Everybody knows that. One of the byproducts is going to be urobilinogen. Now, about 1 to 2% of urobilinogen is going to be always absorbed back into your body. When you're absorbing the food, it's going to come with the food, 1 to 2%. Usually, that's not going to cause any kind of change in your body fluids or your blood, because 1 to 2% is always underlying standard and is always accounted for. But if you are making a lot of conjugated bilirubin, what do you expect the amount of urobilinogen in the intestines to be? Increase. Now, still, you're going to only absorb 1 to 2%. But if you are talking about 1 to 2, let's say just 1%. If you are talking about 1% of 100 is 1. You're going to absorb 1 urobilinogen back into the body because you absorb only 1%. But if you are producing massive amount due to the hemolysis, you are going to have 10,000 bilirubin molecule coming into the intestines. What is going to be its 1% of that one? It's going to be 100. So what you would be able to see is increased urobilinogen in the urine in this case as well. Okay? Increased urobilinogen in the urine as well. Lactate dehydrogenase, I don't like it because it's non-specific. You can see lactate dehydrogenase going up, LDH going up due to different reasons. So I don't like that test. I don't count on to. And I have seen that most of the literature, they stop using that as well. Blood smear and the CBC are going to be the most important one. So again, you're going to have different tests in order to be able to determine what is going on. You know, gastric analysis, if you are using antacids a lot, that's going to interfere with the pepsin function. And if the pepsin is not going to be able to act upon the B12 and the R protein, then those connections are not going to be broken because pepsin is very important, and acidity of stomach is going to be important for the pepsin's function. So that's going to cause a problem because intrinsic factor cannot bind to B12 if R protein is still there. Okay? My God, this place feels like a sauna. Maybe they're quiet now. All right. Questions? I'm getting tired of talking. You guys can. Oh, all of a sudden, 3 of them went up. Cool. Let's start from here. Here.
When you describe that it goes to succinyl-CoA, is that how we obtain energy from B12 drinks and stuff?
Ultimately, it's a coenzyme. So a coenzyme is not being broken by itself. It's just going to act as a carrier or a donor or something like that. By itself, it's not going to change. Okay.
So we drink Red Bull, we get massive amount of B12. That's what it does. So we get energy.
No, the red. What was it? Big Bull. What was it? Red Bull. Red Bull. That's what I have seen the commercial. They have wings and stuff like. No, that's because of caffeine. Because that's going to make your adrenal gland to pump out the norepinephrine and epinephrine. So that's the reason. For the B12, I don't know how. It's very important to know what kind of B12 we are having. Because remember what I said. These are the things that I want you guys to think about. Because these are really where the learning is going to come from. How does the B12 is going to get to the stomach? Come on. It's going to be mixed with the salivary protein called R protein. How many of you chew your drink? That's the thing. There's a story I will tell you later on, not in the class. You know, it's too vulgar. I'm going to just
see you later.
Yeah. Listen up. This is something important. So they might have B12 in there, but I wouldn't expect that to have the efficiently be absorbed into your body. Because in order to have the efficiency, you've got to be able to protect the B12 in the acidity of the stomach. In order to do that, you need the R protein. Where is the R protein? Comes from your saliva. Put everything together, you're going to have the answer. Now, they might have B12. I'm not saying they don't have it, but that's not because they are having the energy. This is all because of caffeine. The second one, Sana?
Okay, when I was pregnant with my son, for the blood results for the postpartum trimester, the doctor told me that there is an 80% chance for optimum folate defect.
Were you deficient in folate?
But I wasn't. I was AFP positive of
Are you O negative? Are you negative? RH negative? Okay, you're RH negative. So is going to get out of this story? We will talk about your condition too. But we're going to go ahead and talk about your condition when we come to immune-related hemolytic anemia. Yours was immune-related because of the fact that some of your blood, the fetus's blood got into your blood, and your blood doesn't recognize that D antigen, that Rh factor, so it's going to make antibody against it. And that antibody is the reason that it's going to cause it.
Even if I have the Rogan shots?
Even if you get the Rogan shot, depends on when the sensitization happened. When you did the exposure to your fetus's blood to your blood. Was it before Rogan shot? Was it after Rogan shot? What was the story? We're going to talk more about it. When we come to that discussion, make sure that we get all the information down so we can ask you questions so you will be able to answer it. So we will be able to solve the case. Tavit?
I had a question for the Rogan piece I talked about.
Sure.
You said that it was going to increase awfully. What was the reason for the increase?
Excessive hemolysis, intramedullary hemolysis. Remember, in this case, the megaloblastic anemia, many cells are going to get bigger, but majority of the cells are going to get so big they're going to hemolyze inside of the bone marrow. They're not never going to see the light of the blood vessels. Okay, so that's why you're going to increase the production of the bilirubin. Okay. Other questions, Karen?
So how do you absorb the B12 like with medication then, if you're not chewing on the pill?
Well, the idea of that is going to be that, that's a good point. See, this is what we call thinking. You're asking questions now. That's good, but I think that when they make the pills, they're going to have the R protein, something similar that's going to protect it against the acidity of the stomach. There is a structure that is going to protect this. But again, this is a good question, because that's going to be exactly the same as Garos. How is that possible? But they're protected. So they are going to be broken down in the pepsin of the stomach, in the duodenum, they're going to be released and they're going to be free. So they will be able to bind to intrinsic factor. That's a good question. Very good question. See, the first day that you guys came in and you felt so strange and you felt so lost and you said that, oh gosh, I'm not going to do well. Now look at yourself. These are good questions that you're asking. These are wonderful questions. So that's good. We are moving forward the right way. All right. Schilling's test. I mean, there are a lot of tests. Some of these tests are not being done very often, but whenever we are doing everything and we cannot determine what is wrong with the patient, then we have to do very rare tests, assays, in order to find the answer. Schilling test is going to be one of those. It's a 24-hour urine. It's not being done very often, because what happens is that, vitamin B12 has a cobalt in it, the element cobalt. So we give the patient B12 with the radioactive cobalt. So we give the patient the radioactive cobalt B12, and then we follow the radioactivity. Where is it going? Is it getting incorporated into the red blood cells? But you have to go ahead and give a radioactive material to the patient, and you have to collect the 24-hour urine, and that radioactivity and story is going to cause a lot of things that you don't want to deal with. So Schilling's test is not being done very often, but it's going to give you the solid answer what is happening to the B12 that you're taking in, your body. How is it going to be processed? Are you going to be able to absorb it? Is it going to come out of your urine? Is it going to go to the feces? Or is it going to be incorporated in red blood cells? That's what Schilling test is. I want to introduce you to something that I don't see you guys being using it in your worksheets in the laboratory. I want to see this word more often. How would you be able to describe this cell, this smear up here? RDW increase. What else? Oh, that's the word I want you to learn. That's the word I want you to start using. Poikilocytosis. What is the meaning of anisocytosis? Variation in size. Poikilocytosis is variation in shape. Isn't that what you're having in here? This is a schistocyte. Yes, it's okay to refer to it as a schistocyte in here. Okay? This is going to be ovalocyte. This is going to be dacryocyte. This is going to be spherocyte. Indicate all of those things. But you also got to, if I want to go ahead and look at this one, I will give you the poikilocyte 2+ minimum. 2+, 3+. That's going to be personal choice, but I will give you 2+ for this one. Because there's too many different morphologies in here. Poikilocytosis. Okay? You go ahead and grade it 1+, 2+, 3+, or 4+. Now at higher magnification, what do you see there? What do you see there? may see polychromasia. In the case of actually megaloblastic anemia, you're going to have lower polychromasia. You're going to have lower retic count because they're not going to make it out. They're going to die. Most of these cells are going to die. They're not going to make it out. What you're saying is that you see target cells in here. So yes, you can see target cells. That's quite common. You see very large cells. Okay, I wish I had a lymphocyte in here. You would see that this cell is going to be larger than the nucleus of a resting lymphocyte. That would be another indication. You got macrocytic cells. And of course, you got the hypersegmented neutrophil. Now my question to you is that what else you know? Perfect. Everything that you see up here is characterizing a megaloblastic anemia, very likely due to B12 or folate deficiency. Now which one it is, you cannot determine that just by this blood smear, but you will be able to do the test to identify which one is going to be. And yes, most of the time, if you are going to have efficiently absorb the B12, you need to get injection, intramuscular injection. Because what we just discussed, when you're taking the pills, depending on what condition it's going to be, you might not be able to absorb it. So this is going to be directly giving the B12 into the muscles, into the blood, and that's going to be the most effective thing. Just be aware of that, that just because you're taking a pill is not going to do anything. For the same reason that I've seen some people, including my mother, that takes calcium, but when you test her vitamin D, she's very low on vitamin D. Now I don't care how much calcium you want to go ahead and take. If you don't have vitamin D, you're not going to absorb any of it in your blood. So it's going to all go through the intestines, it's going to go out. You're not going to absorb it. Same idea. You got to know what the problem is and how to be able to solve it. Just because you're B12 deficient, that doesn't mean if you're going to go ahead and take pills, you're going to be fine. Because you might have pernicious anemia. In the case of pernicious anemia, you're not going to make the intrinsic factor. So you're not going to be able to do it like that. You're going to do it like this. Okay? Alright, why don't you guys take 5 minutes. This is too hot. I don't want to fall asleep. Because I am falling asleep here. So come back in 5 minutes, people. Yeah.